Hey guys, this is Dr. Hub. In case you haven't subscribed, please do subscribe for updates. Congenital diaphragmatic hernias, that is in short known as a CDH. So what is the cause of this congenital diaphragmatic hernia? So this is due to the failure of the closure of. So it is the failure of the closure of the pleuroperitoneal canal. Of the pleuroperitoneal canal, and this is in terms of the developing fetus. So this is in terms of the developing fetus, and it is normally the pleuroperitoneal cavities. It's separated by 8 to 10 weeks of gestation. So normally the pleuroperitoneal cavities. So these cavities, it's separated by. So it is separated by 8 to 10 weeks of the gestation, and mostly the left-sided hernias are common. So the left side is more common, MC more common. Then the two well-recognized congenital sites where the abdominal viscera can herniate into the chest are, so the most common sites where the abdominal viscera, it herniates into the sac, So here the answer is, it is the foramen of Morgagni. So foramen of Morgagni, and so Morgagni. So here it is a hernia in the anteromedial part of the diaphragm. It is a hernia in the anteromedial part, and this is nothing but of the diaphragm. So anteromedial part of the diaphragm with a defect between the sternal and the costal attachments. So there's a defect between the sternal. The defect, it lies between the sternal and the costal attachments. So there's a defect between the sternal and the costal attachments. There's a most common involved viscus is the transverse colon. So most common involved is the TC, that's a transverse colon. Next, we look at the foramen of Bochdalek. So what is the foramen of Bochdalek? So this foramen of Bochdalek is nothing but it's through the dome of the diaphragm. So this is dome of the diaphragm. So dome of the diaphragm means it is posterolaterally, dome of the diaphragm, and this is going to be posterolateral. So some important points to note is that the CDH, it causes the pulmonary hyperplasia. So it causes the pulmonary hypoplasia, and this will be nothing but bilateral, and this is by compressing the developing lung. So it compresses the DLP, that is a developing lung, and these lungs, if you see, they have a smaller bronchi. So these lungs, they have a smaller bronchi, and there is also presence of less bronchial branching. There's less bronchial branching. There is less alveolar surface area than the lungs in normal infants. So there's less alveolar surface area than the lungs in the normal infants. Then there is a pulmonary hypertension, it may also develop. So the pulmonary hypertension, if you see, it can develop, and this is due to the increased risk of the increased thickness of the arterial smooth muscles. This is due to the increased thickness of the arterial smooth muscles. Smooth, let's write smooth because it can mean the skeletal also. So increase of the arterial smooth muscles. and also by the multiple local and the systemic vasoactive factors. This is by the multiple local and the systemic vasoactive factors. Now let's look at the clinical features. So under the C of the clinical features, it can lead to the respiratory distress. So this respiratory distress, it can be seen at birth. Next is the grunting respiration. The presence of chest retractions, as well as the dyspnea and the cyanosis. Next is the scaphoid abdomen. Lastly, the decreased breath sounds. We are writing it as BS. That is the breath sounds along with the bowel sounds. So breath sounds and the bowel sounds over the chest. And this is with the CDH. Next is, it involves the shifting of the heart sounds to the right. So there is shift of the heart sounds to the right, and this is for the left-sided CDH. This is for the left-sided CDH. To learn and grow daily like this, please do subscribe.